Good evening, everyone, and welcome to the 16th monthly webinar for CT and plain film review. My name is Danish, and I'm a product specialist at Collective Minds. I know most of you are familiar, but those of you who are new, this webinar is with Dr. Imran Lasker, who has uploaded some cases to our global community. As you can see on the screen now, this is the global community. He'll be using our workflow and our DICOM viewer to review the images tonight. There's over 3,000 cases currently on the platform in the global community. You should all be able to have access to this. You should have been able to log in. If you haven't, if there's been any issues, let me know in the chat box below. Otherwise, you can email support@cmrad.com and somebody should be able to help you. This webinar is also going to be recorded along with our previous webinars, and you can access them on our YouTube channel. And after the webinar as well, I'll be posting an evaluation link in the chat box. This is just a short evaluation for us, and without it, you won't receive your CPD point. So it is important that you fill that in, and then we can get that CPD certificate out to you. I just want to say thank you to the feedback that came from the previous webinar. It really does help us out. And finally, if there's any cases that you want Imran to look at in the upcoming webinar next month, all you need to do is just go on to one of the cases on the global community, or if you can also upload a case, and then you just need to @Imran Lasker. Just show you now. You can just @Imran Lasker in the comments section. He'll be able to review that, and then he can decide whether to use it in the next webinar. So I think that's about it. So with no further ado, we'll begin, and I'll hand you over to Imran.
So hi, everyone. Hope everyone is well. I'm going to just share my screen now, and then, as usual, try and keep the chat open. So if there are any questions that come up, you can ask. Please, apologies for the noise in the background. I'm at someone else's house, so you may hear some children running around. So hopefully everyone can see my screen. Danish, if you just give me a thumbs up if everyone can see what I'm up to, or just give me an indication that everything's going across. Excellent, thank you. So thank you very much for coming. It's always an honor to do these, and unbelievably blown away that we have so many people sign up. I hope genuinely to give you as much value as I can. In the next hour, we go through some interesting cases. I don't really focus on anything in particular. I just find the most interesting cases I've done over the last month, and people donate cases and that kind of thing. And it just hopefully gives you a little bit of entertainment, also kind of some learning experiences as well, and trying to see the way that someone like myself may go through some cases. So we're going to go to case one. I think we've left the link on here as well. It's amazing to think that we've got 16 of these done so far. That's literally 16 months worth of material that's on the Collective Minds website from myself, and there's lots of YouTube videos as well, which goes with that as well. So yeah, it's a really formidable effort from everyone actually to be able to make this possible. Okay, so what we're going to do, I've got my pen out now, and we're going to have a look at this adult patient, and they've come in with a bit of shortness of breath, right? And so we do have a poll, so most of you will hopefully get this straight away. But have a look, and Danish, if you can just put that poll out and tell them, I'm going to leave it up for people to sort of give their answers, see whatever they think, while I go and talk through this actual image in the background. So we can see here that this patient is an older patient in terms of they are not a young adolescent, because when you actually look at the bones over here, you can't see anything in the way of any growth plates. It all looks very, very kind of normal, looks very uniform, because the bones have actually combined, kind of fused together. So we don't have a young patient here. They're slightly rotated. I feel like they're rotated this way. And for those that don't know how you can tell that, you kind of zoom in a bit, go to pan. And then if we just kind of look at the medial ends of the clavicle, so the medial end of the clavicle there, I feel like the next medial end of the clavicle is there, and the spinous process is over there. So this over here is a bit close to that, which means they're slightly rotated. We don't have a completely en face image here, which is a shame, but these things happen. And then we're going to be looking at the rest of the lungs, right? So there is a big abnormality here that hopefully people can see, and we can see that a few people have put a few answers already, which is really good. Thank you so much. And if you do want to write any answers in the chat box, and you go for it, and I'll try and interact as well as I can while doing this live. So yeah, so we've seen that this patient is kind of very rotated at the moment, but I think the most glaring abnormality, hopefully everyone can agree, is that area over there. It doesn't look quite right. When you look at that lung over here, like so, and then you look at the other area of the lung, like so, you can, yeah, when you do the other end, like so, you can see that this area doesn't look quite right. This all looks very, very whited out, right? So we've talked about consolidation versus pleural effusion, that kind of thing before. But for those that don't know, when you're looking for consolidation, you're trying to see whether there's any of these kind of branch-like areas located over here and over here like this. If it looks like a branch, it's essentially like a straw within a glass full of water, right? And that's essentially what's going on. You've got a straw, which is like the airway, and around it you get a whole lot of gunk. So if you've got a straw with a whole lot of gunk around it, that's probably going to be consolidation. But here, you can't really convincingly see that you can see any sort of radiolucent lines anywhere. It all looks very, very uniform all the way along, right? You can see that. It's all the way along. As well, when you go to the corner, you can see it's kind of lipped upwards like this. And the next time you're having a cup of water or anything like that, you'll see that the water kind of lips up at the end, and that's called the meniscus or meniscal sign. So this is all supporting the idea that this is an underlying pleural effusion that is sitting over here. There's some fluid sitting within the bucket that's over here. So is this a pneumothorax? No, unfortunately, for those that have said it's a pneumothorax, unfortunately, it's not. It's not a pneumothorax because you can see lung markings everywhere. So if we were to sort of zoom in a bit and have a look at the lung markings in the other places, pan this across, use the zoom function on here, and have a really good look, you can see that actually lung markings, they go all the way to the edge, right? All the way to the edge, all the way to the edge, all the way to the edge. There's no sort of radiolucent area like this. That's normally where you find these really sneaky pneumothoraces. And also the other thing you're looking for with pneumothoraces is a sort of, let's just move that out of the way. The sort of bubble-like appearance like this, right? So that's the other thing that you'd be looking for when you are when you're looking for a pneumothorax, like a kind of collapsed lung, because that's essentially what it is. And then you've got your lipped area here, but over here you've got this area that looks a bit more solid, right? It doesn't seem to fit with anything else. So you've got a pleural effusion, and you've got this sort of more solid looking area over here. And actually, when you zoom into that area right within the hilum, you start to feel actually maybe there is a bit of like I'm going to try and draw it for you, a kind of radiolucency like this that branches out like this. So there could be a combination of some consolidation within this area and a pleural effusion. So naturally, like most things, you end up having to do a CT scan. So one thing you may want to do is take a bit of a sample of the pleural fluid and see what it's looking like and send it to the labs and see what's going on. The other areas over here, sorry, I forgot to mention, is that area over there and that area over there looks slightly shadowed. So if we zoom in a bit, it looks slightly shadowed. It doesn't look very sort of conforming to any particular shape. So they could be potentially nodules, or it could be potentially small areas of consolidation as well. So on this platform, which I think is very good, you can download the image temporarily onto your browser, and then that will make for a much smoother scrolling experience when you go through. And pressing 1, 2, 3 gives you the windows that you would otherwise be used to on a proper PACS viewer. So when you scroll through, one of the things you may notice, obviously, straight away is going to be this area over here. You can see that kind of crescenteric area, and it looks like there is some fluid located within the lung. So we can stop there and say, okay, we've got someone who's got a pleural effusion. But coming further down, there are these kind of linear opacities going like so, and they actually look like bands of atelectasis. So you can get little thin folds of lung, and that's called atelectasis. But now when you look in this area over here, let's zoom in over here. Can you see we're talking about potentially areas of consolidation? This is what consolidation looks like when you are looking on CT rather than on an X-ray. And you can see the sort of radiolucency like this, radiolucency like this, like this, like this, right? So that's going to be consolidation, exactly. An air bronchogram. That's exactly what that is, and that's what it looks like. You've got a straw sitting in a whole, like a cup of water, and that's what it is. You've got a whole lot of gunk, a whole lot of pus, a whole lot of fluid, and a little straw going into that, which is the air bronchogram. And so we can see that we've got a combination of things here. We've got this air bronchogram over here, but we've also got a pleural effusion. So we can stop there. But actually, when you look at this particular CT, you can see this is like a little bit of a lip like this, and that looks like pleural fluid. And you can see there's almost a kind of difference in density between this area over here and this area over here. This looks slightly more hyperdense than this. And also, if this was some fluid and just sitting on the back of the chest like this in a barrel, then surely all the fluid should be like this, shouldn't it? Rather than having this sort of almost different mass-like area sitting within that area, within the region of the hilum. And then you can also see that there are a few areas of increased density. So that's something to be aware of. We need to have a look and see on the bone windows whether it conforms to kind of a clumpy circular area or where this is vascular. And actually, when you zoom through, scroot through, you can see they're all linear, they're all continue with one another. If it didn't, then you may be thinking of something like calcified lymph nodes, but that's not what we're seeing here. What we're seeing is vessels sitting within a region which looks like a mass and what looks like a pleural effusion. And there's also some consolidated changes sitting around here. Now, when you look at the rest of the lung, these lungs are by no means normal. We've already said that there are a few bands of atelectasis, but actually when you come further up, you can see that there are these sort of radiolucent areas. And when I say radiolucent, they look slightly more black, right? So you've got some black areas, which are sitting there, surrounded by the sort of more denser areas and a little black area, and a little black area, and a little black area. The person's got a background of central lobar emphysema. If you had it all along the sides like this, it would be called paraseptal. But when it's sort of more within the central areas of the lungs, it's going to be central lobular emphysema. Now, interestingly, when you look at these lungs and come back to the lung windows and kind of pay attention to where this kind of distribution is, you can see the central lobular emphysema is mostly within the upper lobes all the way along the top, and then it goes all the way, and then it's less so apparent as you go further down. And the reason for this is this person either lives in a polluted environment or is smoking, and so most of the aerated lungs are going to be at the apices, and that's where a lot of the damage happens when someone has a smoking history. But this patient, you have to be worried about the fact that this may not just be a post-infection effusion. So someone said, is it hypervascularized inside the consolidation? No, I think these are normal vessels that have been sort of pushed together. And these are, like, so when you look on this area over here, these are your vessels. But then when you've got this sort of consolidated kind of partially collapsed lung, you've got the normal vessels that go through, because it kind of continues through as you'd expect, become thinner and thinner and thinner and dissipate as you'd expect. So I don't think this is potentially a vascular, I don't think this has got new vessels. I think a lot of the bits within the consolidation are normal consolidation with some collapsed vessels. But then this area here, this area over here, like kind of more peripherally, you could say potentially this is a vascular lesion. But over here, this is like normal, this area over here and over here are normal vessels. So the thing we're worried about now is this patient has clearly got an underlying lung abnormality. They've been smoking. You've got some consolidation, which may be secondary to an underlying malignancy. It could also be because of just having a concurrent infection, but you've also got what looks like quite a large mass. The next things with chest imaging anyway is to look for whether there are any lymph nodes anywhere that would therefore suggest that this has spread anywhere. We can't see any lymph nodes. Very, very important to see this mass and see whether it's actually encroaching onto the mediastinum, causing any breach of the mediastinal fat, because that would actually change the staging. Now, one of the things that got me a little bit worried about on this one is that when you look in this area over here, the fat plane that's around the aorta, the fat plane is slightly gone there. So as soon as it starts to sort of invade the mediastinum, it immediately increases the stage. So this is something I definitely mentioned in the report, that there's a lack of fat plane between the aorta and this mass. And then you've got to look for any distant metastasis. So we don't have the entire body, but since we have the scan, we can actually still have a look at the adrenal glands, because that's a very common place to have metastases. And also we can have a look at the liver as well and see whether any hypervascular lesions. Now, the thing about liver lesions is that they can be either hypervascular, i.e. best seen on an arterial phase image, and tumor thrombosis in left lower lobe pulmonary artery. I'll have a look in a second. So you could either get hypervascular lesions, or you can get lesions that are not best seen on the portovenous phase. So in some of the places I've worked, when they do the staging scans, they do arterial phase all the way through to the upper diaphragm to make sure that they get the liver in case there's an arterially enhancing lesion. And then they'll do a portovenous phase doing the abdomen again from the very, very top. So someone says that they felt as though they could see a pulmonary embolus. So one of the things I'd say is a caveat with any of these is have a look if there's any breathing artifact. Actually, this is pretty good. There's not much in the way of breathing artifact. Then I'll usually try and go for a slightly bony-ish window if we've got one. Doesn't look like it. And then you try and look to see where there's any pulmonary emboli. So go along this way. So you're probably feeling around this area here, I suspect, around there, yeah? So this doesn't seem to flow into, if you follow that, it doesn't flow into the artery. It seems to flow into the veins. But there is definitely potential obstruction of the pulmonary veins, right, on this particular image. You've got to look at these arteries and see, look, that's going to be a vein, that's going to be artery, that's going to be artery. I mean, you could potentially say there's going to be a tiny one in that area there. That's potentially possible. Oh yeah, by the way to do that is that you look at this, right? And if that looks like it could be a PE, have a look like at an equivalent vessel of similar size at the same level and see what it looks like. And if they are almost identical to one another, then you may have to say this is more to do with the phase of imaging and the stage at which you took the scan rather than it being pathology. But yeah, I mean, it's a decent thing to raise the possibility of. Unfortunately for this patient, they can have all the cardinal signs, aren't they? They're going to be breathless. They're going to have a high D-dimer because they've most likely got an underlying malignancy, but definitely something to consider. Right, so we will go on to the next case. So this is case number 2. And hopefully this is slightly more straightforward. I think we've done something like this in the past with just another example that came up. So again, this is an adult patient. We can't see any evidence of any non-fused ribs, non-fused bones. Again, yeah, someone's done it. Someone said it's a golden S sign. And I recently found out it's named after the person. For those that do watch that, I learned that from you guys. And then when you look, there is this kind of appearance of what looks like air bronchograms within the area. And then you kind of got this very well delineated sort of area like this. Can you see that? Let's go back to the pen. Pen. Like this, and it kind of looks like an S, doesn't it? Like kind of. And so, and then when the next thing you want to do is just make sure you've paid attention to everything else, right? So yes, you do have what clearly, obviously, a area of lost lung, and it looks like it's a golden S sign, which would suggest that there is a collapse of the right upper lobe. You want to have a look at that hilum and see whether aligned, and actually they look aligned. Sometimes you'll actually have an elevation of the hilum. Sometimes you'll have an elevation of the hemidiaphragm. And the next thing to do is have a look at those ribs. So look at the distance of the ribs there compared to the distance of the ribs there. So you do feel like actually these ribs are slightly closer to one another. So you could say one of the secondary indications of or supporting findings of loss of lung volume or collapse of the left upper lobe and right upper lobe in this particular instance is that you could say that there could be a bit of crowding of the ribs on that side. Sometimes you get a bit of the trachea moving that way as well to compensate for some of that loss of the lung volume. But again, on this one, we haven't seen anything like that. We just see what looks like multiple air bronchograms. We can see what looks like a nice golden S sign, all giving us the appearance that this must be a collapsed left upper lobe. No hilar elevation, no diaphragmatic elevation. And then you just got to make sure you have a really good look around these areas. Just see there's no sort of mass there. There's no sort of masses anywhere else. The lungs are otherwise okay. And very, very important to look in under the hemidiaphragm. By the way, for anyone that doesn't know, my check areas, even if it looks normal, is to look behind the heart, look at the lung apices, look in the costophrenic angles, and look under the hemidiaphragms. Looks like a sad face, doesn't it? But that is your check areas. And in fact, when I was doing my exams, that would be the way that I'd present cases, especially if they're normal. I'd say, this looks like a normal chest X-ray. I don't think the grossly abnormal. My check areas would be the hilar regions, the lung apices, the costophrenic angles, below the hemidiaphragms, and behind the heart. Everything looks okay from my point of view, and then I move on. So that's very, very important to have these check areas, because even if it looks normal in the beginning, sometimes you kind of go through the check areas and something pops up that, oh yeah, good thing I had those check areas in the first place. So for those that are learning, I would highly, highly recommend that you get some check areas sort of going whenever you're doing any sort of reporting. Okay, and I think this is not quite the same case, because on that case we had a right upper lobe collapse, but this is just an illustration of what a collapse can look like. So do you remember we were looking at sort of consolidation. So that was kind of where you got air bronchograms, right? Located within the airways, giving you that sort of linear radiolucency. But on this one, when you look, this is slightly different because you've got kind of the airways, but can you see how there's like that fluid area located there? And you come up and it's all fluid, it's all fluid, it's all fluid. So these areas of fluid are not actually vascular. These areas of fluid are airway plugging. So there's lots of mucus from the airways. And you can know this because if we go to the lung windows, like here, you can see, oh, that's the bone windows. I should know the lung windows by now. And you can go down and you can see that airway there, and you follow that down, it becomes gunky, then more airway, then gunky, and then disappears. And when you go back to the soft tissue windows, you can see there's vessel, there's airway, there's vessel, there's airway. These are all separate and full of what looks like fluid. So there's extensive mucus plugging. It's gone all the way to sort of a more kind of central airway, and has resulted in what looks like collapse/consolidation of the lung. So that's not it. That's not all we're seeing on this particular image. If we reset the images and go back to the lung windows, hopefully they'll turn up, and go right from the top. So we're coming right from the top. So we don't see much in the way of that central lobular emphysema that we saw earlier. Sometimes you have a bit of like central lobular emphysema, especially people like myself who work in the city and all the rest of it. Over time, you can get a little bit of central lobular emphysema, but it's smokers and people who work in those kind of environments that will have slightly more apparent central lobular emphysema. But now when you come down to this area, you can see, I'm going to just draw it so everyone can have a look. Can you see that area there? That doesn't look quite right. Someone said it, yeah. So someone said tree and bud opacity, right? So that's always a good phrase to use. People know what you're talking about when you're saying it. So what does tree and bud opacity mean? It's like, I'm going to draw it on the live over here. So you've got like a tree and a few buds like this, right? And so that's what you're looking for, little kind of tiny little nodules along with some consolidative changes. So we can see that there are a few kind of tiny nodules kind of scattered throughout over here. They look like there's kind of branches of sticks as well. So that's going to be part of this consolidation. But actually also what I wanted to highlight is if we zoom in even more, we can see the airways again, and slightly different from the airways we saw before. So far we saw airways with lots of gunk around it, which would be consolidation. Now we've seen airways, which are just full of fluid. So that's called mucus plugging. But now you've just got a thickening of the airways. Can you see that? So that's the wall there. That's the airway wall there. That's the airway wall there. And that's the airway wall there. All looks very, very thickened. So you can actually say there's thickening of the airways, which can be secondary to inflammation or infection. Can you see? Nicely thickened there as well. So yeah, exactly. So someone says, could it be bronchiolitis? Yes, of course. Any sort of alitis, inflammation, can result in this sort of thickened sort of bronchiectasis rather than a different kind of bronchiectasis, which we may go through today, or another case when we've got one. But yeah, so on this particular case, we've got what looks like consolidated changes located in that sort of right lower lobe, and we've got collapse of the lungs over here, and then we haven't seen much in the way of any lymph node enlargement, and the mediastinum looks okay. And if we kind of scroll all the way down to the bottom, very, very important just to have a look at the upper abdomen as well, just to make sure there's nothing grossly abnormal. So now you've got this area of consolidation, mucus plugging, collapse, and then you've also got the peribronchial wall thickening and the foci of consolidation and the tree and bud opacities. You can be more inclined to think that this is going to be an underlying infective cause rather than some sort of malignancy, right? Because we haven't seen a big mass anywhere. We haven't seen, you know how before we had that sort of big bulbous mass sitting on the hilum? We don't have anything like that. It all looks very kind of fluidy, gunky, and that kind of thing, rather than being an underlying malignancy. So obviously you'd correlate with the clinical history. You look at the blood films, you look at the blood markers, see what they all look like, and come to your eventual conclusion. And hopefully for this person anyway, it wouldn't be a malignancy. It's more likely to be a underlying infection, right? So yeah, exactly. So someone says that 9 out of 10. Where did you get that stat? That'd be interesting to know. But yeah, generally speaking, you would say that tree and bud opacities would be to do with infection. So again, like I was saying, like the fact that also, you know, generally, if you've got a malignancy that's on one side, to have like another malignancy on a different lobe will upstage it massively, right? That's really cool. Rad's book from the US. I might check that out. Can you send me a link? So this is quite an important finding. It's not, so what you don't want to do is see that collapse/consolidations move on, right? The other signs actually gives you the idea that actually there's more likely to be underlying infection/inflammation. Okay, so this next case is abdomen. They've come in with abdominal pain, and there should be a quiz thing for this one. So if we could just get that up for you guys while we have a look at this X-ray. So this patient came in with abdominal pain, and generally speaking, I don't know how useful it is for people to do abdominal X-rays these days, because even if it's normal and they've got pain, you end up getting a CT, don't you? But okay, so first off, let's have a look and see what the bowel looks like. So where is the bowel? We can see that the bowel is sitting within this. Let's go here. We can see some of the bowel is sitting over here. Some of the bowel is sitting over here. Maybe some bowel is sitting over here, but none of it looks particularly dilated. And then when you look at these areas over here, these are called haustra. So large bowel will have lines that go all the way across, and that's what is called haustra. That doesn't look particularly dilated. And then small bowel will be more centrally placed. We don't see any sort of dilated airfield bowel within the central abdomen. And then I say haustra don't go all the way across. These look like they might actually. I don't know why it looks like that. But haustra would go all the way across, and valvular convergentes would go all the way across. Haustra do not go all the way across. Sorry, getting confused here. But generally speaking, you don't see any airfield bowel obstruction. And actually, when I do my reporting of abdominal X-rays, I do say no evidence of air-filled bowel obstruction, because if it's fluid-filled, sometimes you can tell. Sometimes if it's really fluid-filled, you can't 100% see the bowel. And I've seen normal-looking abdominal films go on to have what clearly is significant large bowel, small or large bowel obstruction because it's so fluid-filled. Okay, so we've got a few people saying pneumoperitoneum. Now, pneumoperitoneum, you'd really be looking for air on both sides of the bowel. And I used to find that a really difficult concept. But what you're doing is you're looking at the bowel, you can see the other bowel there, but you want to see if there's any air on the other side. Oh, wow, you've actually written a thing. Okay, I'm going to have to read that later. Thank you. I wasn't doubting, by the way. So anyway, we got this bowel over here like this. And then what you want to do is see if there's any air-filled air on the other side of the bowel, and that is where you sharing is caring. Yeah, I must care a lot then. Someone said sharing is caring. Okay, so then what you want to do is see if there's any air on this side. And if there's lots of air on this side, you'll see the interface between air, bowel wall, and then air within the bowel wall, and then that would be consistent with a pneumoperitoneum, right? Someone says a pacification haziness of the pelvic inlet. So yeah, you can get a bit duped by something like that. I mean, that could be the urinary bladder. So I wouldn't really, unless it's completely obvious, I wouldn't be too worried. So let's just say, look, we can't see anything going on. Oh, someone has smashed that. Okay, good. So someone has come out with it. So what we'll do, I'm not going to say that just yet. Let's just go through the CT scan. So we are now going to go through the CT scan, and this is the same patient. So actually look at the lungs here, since we've been going about lungs today. We can have a look, and actually, yeah, it looks like there is a few air bronchograms located there, potentially a pleural effusion. There's also a kind of thin line there, which is some atelectasis, a kind of folded lung, a very thin band. Now, this looks like a non-contrast scan because there's no kind of brightness within the aorta, no brightness within the portovenous system either. We can see the liver is over here. Where's our gallbladder? Gallbladder's over here. Can't see anything abnormal with the gallbladder. Coming up to the kidneys. Oh yeah, feel free to put your answers down. Yeah, exactly. So then you're looking at the adrenal glands, and then you're looking at the kidneys as well. Okay, so a few people have gone for something weird, which is actually kind of true. It's not entirely straightforward. Okay, so and only becomes more straightforward as you go to the CT scan. So now we've come up to this area, and I don't know if you guys can see this, but this doesn't look quite, oh, sorry, this area doesn't look quite right. Can you see that? When you compare this little area here compared to this, that area looks like more cloudy, right? So there's something going on in this area, right? Okay, even if you didn't see that, I would use this particular way to go through any scan. Gallbladder, kidneys, how do they look? Look at the pancreas as well. The pancreas is sitting somewhere here. Can you see that? It looks a bit atrophic, which can be normal for people. Interestingly, I remember when I was doing my actual exam, I couldn't find the pancreas, and me being me, not being a very confident person, I thought to myself, that's because I'm not very good at this. Well, that's why I can't find the pancreas. And it turned out, actually, it was called ghost pancreas because the patient had cystic fibrosis, and because it becomes so fat infiltrated, it looked like it wasn't there, which is really interesting. Well, for me anyway, I find this stuff interesting. All right, so then we come down to the bowel, and you can actually see here and here. So let's draw that here. Over here and here, you can see this sort of circular fatty areas over here. So they've got inguinal hernias, but we can't see any evidence of any herniated bowel anywhere. So now what we'll do is go through to the, follow from the rectum, going all the way up. We can see the bowel goes that way. My mouse is still on the bowel. Oh, it's difficult to follow this one. Does it go back on itself? I'm going back on myself. Let's see where we are. So you know what I do? If I ever get lost, I go for the constant. So one of the constants is going to be the descending colon. So descending colon going all the way through like so. Oh yeah, there we go. Descending colon coming up. Then it connects like this and connects like this. So then you can see that, yeah, okay, so that's going to be the descending colon. We'll go across the transverse colon like so, going all the way across, Hepatic flexure looks okay. start to look a bit unhappy. You see that's all around here, looks very, very unhappy. And then you got a whole load of area of bowel that looks very, very unhappy. And I'm going to draw that out for you. Look at that area compared to, let's say, that area. It looks very, very fluffy, looks very, very edematous. The bowel wall looks very, very thickened as well. So that's not good. And actually, what you can do is if you go down here, you can see there are multiple lymph nodes here. You can see that lymph node there, another lymph node there, and then there could be something sitting in there. Maybe they've eaten something like something that's not great for them. But actually, can you see there's a blind ending loop? So that, if you spot that, and then if I get rid of my pen mark and go down, 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 that looks slightly thickened as well. But actually, most of pathology is located within this area of bowel. And when you follow that piece of bowel upwards, 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 it should go into the cecal pole. So cecal pole is going to be somewhere here and then kind of continues in. And so that's going to be around this area here. So actually what you're looking at is exactly right. So terminal ileitis, exactly. So that can be for a few reasons. You can get backwash ileitis, you can get Crohn's disease, I think you can get some infection like Yersinia, something that can cause some terminal ileitis as well. So this is a quite interesting case, and you think, yeah, you know what, well done, everyone's happy. But some people have pointed out something very interesting. They've actually gone from the X-ray, maybe even gone on to the CT scan to try and confirm their findings. But actually, when you look at these sacroiliac joints bilaterally, can you see that? Can you see that? They're very fused, aren't they? And then you come up, come up, come up. Let's go to the scroll button. Come up, come up. These joints here, so I'm going to draw them out for people. If you keep your eyes there and there, these facet joints look like they're kind of slightly fused, like they're ankylosed, right? And then what we can also do, which is I think really phenomenal of this platform, is that you can do NPR, go sagittal on this. Now you can see that there is this flowing calcifications. Can you see that? Flowing calcifications. What people okay, arthritis easier for surgeon. Let me evaluate. Okay, so then you go along like this, going all the way down like this. You can see this sort of calcification like this, calcifications all the way along like this. And so this looks like ankylosing spondylitis, right? Now, one of the things that scares me about ankylosing spondylitis for patients is that any sort of trauma, especially when they're that stage, can result in fractures, because what ends up happening is that you get a translation of forces across, all of a sudden, you can end up with like a 3-column injury from very little, like very, very little. So you've got to be very, very careful with this kind of thing. Like just make sure you've had a good look at the bones, because in fact, once we had a patient who came in and they had a CT scan for something completely unrelated, and there was a fracture there, and they came in later and it slightly moved because it was unstable. So very, very important that if you do have someone that's potentially ankylosing spondylitis, you do have a look. And then we have a look at here, and actually is there all along, someone said dagger sign. You can see that sort of flowing calcifications located along there. How common to see lymphadenopathy in IBD? Not sure, actually. I mean, I would assume that you'd see it more often in infection, because it wouldn't be, I mean, yeah, most of the time when I see these colitis, actually we've got a colitis coming up, you don't see lymph nodes. Lymph nodes, generally speaking, would be because of some sort of underlying infection and that kind of thing. But feel free to correct me. But I thought this would be an interesting case because sometimes a second finding, I've said this before on a few different talks, that often it's the second finding, the most commonly missed finding is a second finding. And in this particular case, although it's not entirely clinically relevant, the second finding was the patient's got underlying ankylosing spondylitis. So I think that kind of brought in a fair bit of discussion from what I can see. I'm glad that is what it's done, because that's what I'm trying to do, get everyone to enjoy and also think about what's happening. This one, have we done this one? Why has this come up again? This is lung windows. I feel like we've done this one. So my apologies. Let's go to the next case. We're doing pretty good for time, so we've got plenty of time. So next case. Just for, oh, well, I hope you're all right, mate. COVID's not great. I had that once. It was horrible. I went to, and in fact, I went to watch a movie. It was a new Batman film. And I thought, it's a bit cold in this cinema. Like, why is it so cold? And I was shivering. I was going to go complain to management. Then I realized, you know what? I don't think I'm very well. And when I got back, it turned out I had COVID. So anyway, everyone's got their time. Anyway, so this is a CT head, not quite a CT head, the CT angiogram of the intracranial vessels. And it looks like it's only the intracranial vessels. We haven't gone for the aortic arch or the vertebral arteries. Now, when you scroll through this one, let's go from the very top, all the way down, all the way down, all the way down, all the way down. Hopefully people can, has anyone seen it? Has anyone seen it? So what you're looking for with these vessels is to look for any sort of outpouching. So any potential weakness, so some connective tissue disorders can result in aneurysms and that kind of thing. But sometimes you just have an aneurysm, and they normally happen at these kind of like trajectories or areas of confluence, right? So I assume it's because the way the blood vessels are, if they're kind of going onto a corner like this, there'll be a bit more turbulent flow within that area as it kind of takes that corner, and you end up getting sort of a weakness and stuff like that. And actually on this particular one, what we've done is inject contrast, timed it so that it's in the arteries at the time of the study, and then we have taken the image, right? Actually on this one, you've got a pretty decent image of the let's try and get this back. You've actually got a pretty decent image of the venous sinuses as well, which I'm pointing out over here, the sigmoid sinus, and you've got your, sagittal sinus going all the way across. So it's actually quite good for that as well. But the real reason why we're here is because of what looks like this, the area over here. You can see that coming right off that, and exactly right, anterior communicating area over here, and looks like a very globular appearance. Normally vessels kind of flow into one another. This one doesn't flow into anyone, right? It just sort of turns up and then just stays there, just disappears, stays there, disappears, stays there, disappears. So you can imagine it's like a little bit of a balloon, and over time it can fill up and get a bit weak, and then eventually end up having end up bursting. Someone has said remnants of right-sided sinusitis. Yeah, you know what? It looks a bit more like a little polypy. It looks a bit like a circle. So it could be like a polyp. Yes, it could be sinus disease. The rest of the sinuses look okay. No bone abnormalities whatsoever. This is quite a large aneurysm, and will therefore most likely need to be looked at by the neurosurgical team. They may want to put a coil in, because something like that could be a bit of a ticking time bomb. Right, let's go to the next case. So this is so we've kind of gone for like quite difficult stuff, and hopefully this one will be a little bit easier, because some of you guys actually seem like you're quite learned, quite good at imaging already. So let's have a look. So we've got X-ray here, and genuinely one of the first things I do, I look at that base of fifth, right? The base of fifth is that sneaky guy over here. You'll be very, very sure that you've had a look there, and then I just have a look and make sure that anything in the foot I've had a look at, and actually everything looks okay. I've seen fractures of the navicular pop up in these ones, so you got to be very careful. Then you look for osteochondral defects. So I know I'm doing things slightly backwards, but the way I do things, and I would encourage people to do, like, some things are just obvious. Fair enough. They're obvious. You see it, boom, you're done. But it's actually very important to look for the less obvious. And so therefore, over time, I've ended up making like the less obvious things, the things I look for, and then go on to the obvious things. So osteochondral defect, they're like a little defect in the talar dome, usually be in the supramedial talar dome. That's where you usually get osteochondral defects. This one we don't. We do have a bit of soft tissue swelling here. That doesn't look quite right. And if you look at your own fibula, hopefully you just got skin that goes right against the fibula, but that looks a little bit edematous, a little bit swollen. And actually, when you look at this, you can see there's a bit of a discrepancy sitting over here. So yeah, there's not quite the best forward view, right? Generally speaking, it should be kind of straight sort of AEP, but it's not quite that. And now when you go to this view, it's a little bit more obvious, right? You can see that there is what looks like this linear line lucency going along like so. And what you really got to do is try and draw where that belongs to. And if you draw that, you can almost see that it's probably going to be the fibula. The tibia looks okay. Again, I'd also look at the more unusual things as well. So you look at that calcaneum, look at that trabeculation, right? Make sure that that's all linear and nice. You don't want to see underlying, you don't want to see any stress fractures. Again, have a look at that navicular over there, and have a look at the tarsals, metatarsal bones. Sometimes you actually have like a little fracture sitting in the distal calcaneum as well, right? So just be careful to have a good look around and make sure that you've had a good look around everywhere. Someone said about the syndesmosis. I don't think this is a great one to look for the syndesmosis, slightly, only because they're kind of slightly rotated, so you might get a slightly oblique view of it. Main thing is that you look at all these check areas and then go for the obvious, right? Check area, then, check area, then the obvious. That's the way to do the plain films, I think, because it's a second fracture that gets missed. It's the things that you didn't expect. Like, people will come in with ankle pain, right? But then actually they've gone and fractured their big toe. It's the weirdest thing, but that's just the way it is sometimes. Like, people end up fracturing a complete different part of their body. So let's have a look at this X-ray. let's go straight for this one. So when we zoom in on this, so I'm going to go through the check areas that I would do whenever looking at any sort of foot image, is I have a look at those metatarsal heads, right? Make sure that they are nicely contoured. There's no increased sclerosis, because then you'll be looking at Freiberg's infraction. Then you want to be looking at the metatarsal shafts and make sure that they are all nice. There's no fuzziness to it. And even a subtle amount of fuzziness can actually be an indication that this person's got a stress fracture. I can't say I can see that. Then what you want to do is have a look at the terminal phalanges, right? Terminal phalanges or the terminal tips. I've seen fractures. People have stamped on their toe, stubbed their toe, all sorts of things. Very, very careful. You've got to make sure you don't miss that. And then you want to go for the slightly more obvious stuff as well. Base of fifth is always a good one. Look for whether there's a fracture there, but actually that looks okay. So you may think to yourself, you know what, everything's good, we're going to move on. But actually, the next thing you want to do is have a look at the alignment of the tarsometatarsal joints. And this is the tarsals. These are the tarsals. These are the metatarsals, right? You want to see if they line nicely, especially this sort of interface between the medial and middle cuneiform. See if that lines up quite nicely, because then you may be wondering if whether there could be a little ligament here called the Lisfranc ligament. If that tears, then you can have a complete shift of all the bones across. But when you look at this, let's draw this out. That looks okay. Coming up to here, there's like a linear line there and a linear line there, and then you've got more bone and you've got a whole load of overlap. But to me, that does not look right. And I would be concerned that there could be an intact Lisfranc ligament, but because it's kind of pulled off from there, this could result in sort of transference across, right? So then you may want to have a different view. You zoom in, you have a look. Oh, it's not so obvious, but there does seem to be something sitting there. It doesn't look quite right. And again, you want to have another look on a different view. It's not so obvious. I don't think it's an easy scan, but I would definitely go away worried that this person's had an underlying fracture of that the base of the second metatarsal, with some communication with the tarsometatarsal joint as well, which is very important to take into consideration. Also, remember the sneaky fractures that you can get: base of fifth, fibula. See if you can see any sort of anything going on in the tibia and navicular. Make sure you've had a good look at everything to see if there's any fractures anywhere. Right, let's go on to the next case. We're going back to CT, and we're going to have a look at this particular case. So this is an adult patient. They've come in with abdominal pain, and this looks like it's jumped for some reason. I don't know why. So renal malrotation. No, I don't think so. I think if we draw the kidneys, they look like they're there and there from the kidneys that we can see. You know, maybe I should reload this one just in case it's a problem with the downloading. Otherwise, it's just for some reason hasn't worked with the upload. Let's download that. Okay, let's see. No, it has jumped, hasn't it? Okay, so have a look at this one. Do answer the questions if you can. We're going to do one scroll through. I think even though I don't have all the images, I think we should be able to answer most of what we need to answer based on what we're seeing. So we scroll through. And actually, we can't see much there's not much to really see here. But with regards to, is a small bowel obstruction? Small bowel is located within the central area over here. So no, it's not obstructed. This can be the large bowel over here, and they don't look particularly dilated. So we're not saying it's dilated. Unfortunately, I can't see the appendix because we haven't gone far down enough. For some reason, some of the images aren't there. But we can see from this is that there is some inflammation of the bowel. So if you look at that, what looks like transverse colon, look at that bowel wall. Very, very thin. When you come up to the bowel wall over here, it looks very, very thick. So now when you look around, you can't see much in the way of fluid, maybe some fat stranding, not much in the way of lymph nodes on this scan, from what I remember. Unfortunately, I can't show you. But what you can see is that this looks like sort of inflammation, right? And this looks like it's going probably to the splenic flexure and involving the descending colon. Now, why is this important? It's all about distribution, right? So you can get colitis. You can get colitis that affects certain aspects of the bowel. Like we saw earlier, we saw there's inflammation of the terminal ileum, right? But what we see here is that we've got exactly right, enhancing, thickened, large bowel located within the left abdomen. So when you're looking at the vascular distributions, I'm going to draw on this area over here. So let's say this is the large bowel, like so, right? So what can happen is that you can get sort of blood flow kind of going this way. You got a different branch going this way and like a different branch going this way. So if you get like obstruction of these particular areas, you can actually get segments of bowel that are infarcted. And then actually you get a bit of overlap here called the watershed area, where a few vessels from one area and another vessel, a few vessels from another, result in some sort of cross fusion or cross vascularization. And in this particular case, what I was going to try and show is that actually this does have a bit of a distribution to do with a splenic flexure all the way down to the sigmoid colon. And so when it's something like that, and you don't have much in the way of lymph nodes, you got to start worrying that this could be not just colitis, but something like underlying ischemic colitis. So they may need to keep a watch of the lactate, see how the patient's doing, and have a bit of a lower threshold to go in. So so those that said is colitis, you're right. I apologize for not having the whole images. When I did check earlier, it was there. Not sure why it's not loading up right now. Right, so let's have a look. So a lot of people said small bowel, a few people said small bowel obstruction, a few people said large bowel obstruction and appendicitis. So how do you say appendicitis? Unless you're getting the images I'm not getting. Appendicitis, I'm going to show you the appendix for those people that may have thought it was appendicitis in just a second. So let's go to the CT scan. We'll go from the top and feel free to put your answers in. What we'll do, since we've been talking about lungs again, well, let's have a quick look at the base of the lungs. And you can see there's linear sort of cobweb style. Can you see that? They look like cobwebs. When they look like cobwebs, you're thinking to yourself, this is bands of atelectasis rather than anything else. We don't have, yeah, you can call them reticulation if you want. Reticulation, generally speaking, you know, like you use reticulation when you get like lots of thin bands, and I usually use it if I'm talking about something like interstitial lung disease. But when you get this sort of irregular, you know, thin or thick bands sitting around, I just call it thin bands of atelectasis and leave it at that. But maybe that's just a personal preference. Everyone's got their own way of reporting, right? So now let's go from the top. We can see that this is a contrast in our study. We can see the portal vein sitting over here. We can see the liver is sitting over there. And this patient's come in with abdominal pain. So one of the things I would do is have a look at that gallbladder. Make sure it looks okay. Doesn't look particularly inflamed, which is good. Let's have a look at the kidneys now. Kidneys look okay. They don't look particularly inflamed either. And then the pancreas is also one of those big ones that cause a lot of abdominal pain. Pancreas, that is that kind of fluffy thing. I'll show you here. Look, going along like this, going along like this, all the way along. It looks okay. Doesn't look particularly inflamed. So we're not looking at pancreatitis at all either. So now we've got to do a bit of a long haul. Some of you may have seen it. I know some of you may have seen it. Well done. But I'm going to go for the people that don't know how to do things. I will run of the mill. Yeah, not so run of the mill for the person feeling it. It's like the biggest thing in their life, isn't it? So then what you do, you go from the rectum, you go all the way up, all the way up, all the way up, all the way up, and you follow it, right? Follow it, follow it, follow it, follow it, follow it. It seems to be a very tortuous one. Goes across like this, does it? Goes back down again. So like that sigmoid cone's gone all the way up, all the way down, back up again. So now we're in this region over here. We follow up the descending colon to the splenic flexure, gone all the way across, transverse colon, all the way across, all the way across. Now we are coming up to the transverse colon. We come to the hepatic flexure, come to the ascending colon, coming all the way down, all the way down, all the way down, all the way down. And then you want to be looking for this fatty lips. Sometimes you can't see it. See if I can find these fatty lips. Yeah. So if you look in this area over here, that's going to be somewhere around the ileocecal valve. You can see some small bowel coming out there. They look like some lips. Let me see if I can draw it for you. So you can see that. I don't know. Yeah, look like little lips. And you've got your small bowel coming out of that. Very important if you can to try and find that, to know that that's not the appendix. And you can see that's not the appendix. It goes into the ileocecal valve. Coming further down, then you start to see exactly what people are saying. This kind of blind ending loop looks very, very inflamed. Now we just got to follow that finger kind of all the way up. Follow it, follow it, follow it, follow it. And then it disappears. So also when you look in this area and compare it to this area, you can see there's lots of fat stranding, but this fat looks very, very normal. So you've got a blind ending loop, definitely separate from the ileocecal valve, and it looks very, very inflamed. So that's very important. So we're looking at appendicitis. Next thing you want to do is have a look at the lung windows. So this is what air looks like. You want to see if there's any air located within this area, because then that would be a perforation. I also actually these days make sure that I have a look at the rest of the abdomen for any air, because I've had a situation where there was no air located in the region of interest, like the inflammation, but there was air everywhere else. So it may have been someone that has perforated, sat around, it kind of sealed itself off and all the air is kind of sitting around. How old is this patient? Youngish. I can't remember the exact age, but the reason why I'm showing you this is that, first there's no there's no collection, there's no perforation. Now you know what the appendix looks like. For those of you that don't know, you can see that's very, very inflamed. And then the rest of the bowel looks okay in some of the check areas. Now, the reason why I brought this up is because not very long ago, can't reveal when, but not very long ago, I was doing an on-call, and then I got called saying, "Hi, Dr. Lasker, can you report this MRI abdomen?" And I was like, "Listen, I don't normally do MRI abdomens, especially on call. I don't do MRI abdomens in general." And it turns out they had a very young patient that they didn't want to stick in the CT scanner and they want to do an MRI scan instead. So I thought, okay, I'll have a look. And obviously, I didn't do it on my own. I did get one of my friends involved who is a gastroradiologist, and we went through it together. And it turns out that on some occasions, it may be worth doing an MRI scan, especially if the patient is very young, looking for appendicitis. And if we just treat it like a CT scan, and I'll tell you a little bit about MRI, or bits of MRI that I understand anyway, is that if you look at the area over here, that's your spinal canal, right? And in that area, there's some spine that is very, very bright. So this is a T2 weight image. Basically, fluid is going to be bright on this image, right? So as you come down to around this area, you can see that this is the fat here, but all this looks a bit strandy and looks a bit kind of bright, a little bit like that CSF fluid. Coming further down, it just doesn't look quite the same as the other side. And as you come further down, you can see that there is what looks like some sort of circular spherical bowel wall thickening there. That doesn't look quite right. So let's see if we can go further down. Yeah, that goes all the way down like so. And then it seems, seems to just finish there. See that? Goes up, down, finish right there. So therefore, this would be an MRI appearance of a of appendicitis. And interestingly, they hopefully it's come across. So let's see if I can show it to you on this image. Again, you can see lots of fluid located within that region. And then what? How old? How should we consider underlying factors? I mean, appendicitis can happen at most ages, really. Anyway, so where's the diffusion weighted images? Maybe they're here, so I've got to scroll through. I'm going to just mess around with the windowing. Maybe that'll help. So when you do the diffusion weighted images, you can see that there's linear area over here is very, very bright, which corresponds to, yeah, exactly. So on diffusion weighted images, what you're looking for is whether they're, the way I describe it to anyone that I'm trying to teach with my basic knowledge is that water likes to fly around, basically, likes to be free. And if it gets restricted, it starts to kind of have this pent up energy, a bit like if you're trying to hold your toddler down and they want to go play or something, right? So when you do restricted diffusion imaging, if you've got restricted fluid, it starts to have that pent-up energy, and you see that pent-up energy. And so with restricted diffusion on an appendicitis, it actually looks kind of bright compared to everywhere else. And that's because it's become very edematous, and the fluid just can't kind of go to the place it wants to go. And you end up getting this kind of image where you've got restricted diffusion, lots of fluid, blind ending loop, lots of edema around the area. So I thought it'd be interesting because although they're not the same patient, we've seen what appendicitis looks like on CT, and now we've seen what appendicitis looks like on MRI scan, which is, I think, still pretty rare. People don't always do it, but there are occasions where we do it. Right. I think that is the end of the talk. We're coming up to the end of the session. So as always, I do genuinely appreciate all feedback, even if it's bad. If you think I'm not very good, do let me know. I do want to be as good as I can. I want to give you guys as much value as possible when you do these sessions together. As you may know already, I do like to teach. I do make a pastime of teaching, spending my evenings doing this kind of stuff and thinking about different ways to explain things and help you guys. So any feedback would be great. And as always, we've got to also give a big props to Collective Minds for making this all possible. The fact that we can all together go through the images on something like this live, and then you guys can go check it out later on YouTube. Yeah, so someone's asking for recordings. You'll be able to log in to Collective Minds. I think they put the recordings on there, and also you should be able to find it on their YouTube channel where you'll be able to watch this video, go through the cases live, and pause and all that kind of thing if you need to, and speed up my talk and you think I'm too fast, or slow it down. You know what I mean. Whatever works for you. All right. So from me, as always, have a great evening, or wherever you are in the world, morning, wherever you are. And I do appreciate everyone's, yeah, you're welcome. And there's a feedback form that's come through there. Do please fill out. So from me, goodbye. I'll hand over to Danish.
Thank you, Imran, for another great interactive session. And thank you for everyone that's attended this evening. Please do try the link below. Please let me know if it does work and if there's any issues with it. And just remember that you will only get your CPD certificate once you've filled out the entire feedback. And we shall see you on the next webinar next month. Look out for the date. It should be available to you all very soon.